Retrograde intracranial surgery for symptomatic calculi and calyceal diverticulum. As you would agree, calyceal diverticulum is a very interesting rare congenital anomaly in which there is outpouching from the pelvic-calyceal system which projects into the parenchyma. In this outpouching, there can form stones and infection, and most patients present because of formation of stones and pain related to these stones. The treatment is usually needed to manage the pain and recurrent infection. The index patient is a 40-year-old obese lady who presented with left flank pain. On evaluation, she was found to have a cluster of calculi in the region of mid-calyx. Intravenous urography showed all these calculi to be present in a calyceal diverticulum rising from the middle pole of calyx. In view of her obesity and anteriorly placed diverticulum, a decision of retrograde intracranial surgery was taken. The first step of RIRS was to do a retrograde paleography. On retrograde paleography, the calyceal diverticulum got filled with contrast. It was arising from the mid-pole region. Flexible ureteroscopy was done. Papilla showed calcification, which shows that in calyceal diverticulum also the cause for stone formation is probably some metabolic anomaly. Despite a thorough check of all the calyces, the neck of diverticulum could not be seen. The attempt to identify the neck was done both endoscopy and fluoroscopy guided. Here, behind the thin mucosa, suspicion of stones is there, and this corresponded with the middle calyx. Hence, the methylene blue test was planned. A diluted methylene blue is pushed in the pelvic calyceal system, and once it is drained from the PCS, an attempt is made to see from where the methylene blue comes in. Methylene blue efflux was not seen, and hence we decided to incise on the thin mucosa overlying the calculi. With a low power of holmium laser, a small incision was made on the thin mucosa, and you could see the calculi behind this thin mucosa. Once calculi were identified, then boldly this incision was enlarged to make an opening enough for the calculi to come out. Once the diverticulum opens, these multiple small calculi pop out of the diverticulum into the pelvic calyceal system. Gradually, the diverticular neck is enlarged. Holmium laser, because of its brilliant cutting and coagulating property, this procedure can be done in a nearly hemostatic way. Opening large enough for the flexible scope to enter was made. Most of the calculi seem to have come out of the diverticulum. Now inside you can see few large stones which were fragmented by holmium laser, and now all calculi from the diverticulum are in the renal pelvis and would come out in due course of time. At the end of the procedure, a digestant was placed. The digestant was placed because a lot of gravel came in the pelvic-calyceal system. It is not important to keep the stent across the diverticular neck because most often than not, the stent would not stay across the diverticular neck. This patient has been on follow-up for more than a year and has been doing good. The calyceal diverticular neck has remained open and she has not formed the stone again. The methylene blue test was tried in 5 patients over the last 3 years to identify the diverticular neck. In 3 patients, we could identify the neck and neck could be opened up with holmium lasers. In 2 patients where neck was not identified but stones were seen behind thin mucosa, blind incision over the mucosa to remove the calculi was done. RIRS can be safely performed for calculi and calyceal diverticulum. If neck is not identified, blue sprit technique can be used. Fluoroscopy controlled opening of the neck if mucosa over the diverticulum is thin can be done. Thank you for a patient hearing.